I got it. Okay. Again, keep in mind these are also Diego's outlines, so it's a little different than how I set my stuff up. So bear with me again. So at the top, anything that's in this color is extra information, just kind of like a nice to know. Yellow is what he deemed to be important. So for types of injuries, it's just nice to know you have hyperflexion, usually like a whiplash injury, hyperextension, so usually like a rear end accident, compression, like I love seeing those videos. I mean, it's not a good thing, but like those videos where people like jump off the roof and they land like square on their butt on the ground, that would probably be a compression injury. It sounds like you're, compressing your spine. Not good. Rotation, turning the head too far, it's rotating too far, and then penetration. Exactly what it sounds like. Stabby, stabby, crabby, crabby. Let's see. We have complete versus incomplete. So you have a motor and sensory incomplete. So with motor, some motor function is available, but you have a little bit of lack of sensation. With sensory, you have some sensation, no motor function. And then the complete is the big bad. So complete injury of the spinal cord. So loss of both motor function and sensation. All this extra stuff. Spine function, we know that it is it's a big support. It makes sense. It's part of your back. It's your torso support, pop off cis. It protects your spinal cord. Blah, blah, blah. Sensory tells brain about positioning, pain, temperature, touch, etc. Motor moves and holds is the backbone of stuff. This is something that would be important to know. And this will come up and we'll talk about the specific levels of injury for certain conditions later on down the line. But levels of injury, you have your C3 to C5. Anything here can have breathing issues. So anything above that, breathing issues, know that. C1 to C8 is quadriplegia, and T1 to L4 is paraplegia. Probably just know this top part. So here's your examples of paraplegia, hemiplegia, and tetraplegia. Nice. When you have someone that you suspect is coming in for spinal cord injury, oh, sorry. C1, C2 isn't correlated with breathing. Yeah. I believe this is the main one, the C3 to C5, but let me double check it really quick. I don't trust Diego because he forgot to put some stuff in his last outline. Yeah, I'm going to call him out for it. I don't care. Let's see. Where is it? Hey kiddo, I'm working. Can you go sit down over there, please?
I can.
Thank you. Oh, these are the outlines still. Sorry guys, give me one quick second. Here we are. I don't want to tell you guys wrong information either. Control F, C3. Where are we? Does it mean anything above that? Oh, here it is. It's further down here. Okay. Let's see. Major cause of death in acute phase. Above C4, 5. So higher risk of injury. Just think C5 and up is going to be breathing issues. I think that would be a better way of saying that. Let me rewrite this. Yeah, because I was like, I don't inherently like the way this is written either. Yeah, I'm going to throw shade. I don't care. Causes respiratory. Jesus, there we go. I'm sorry, Theron, my bad. Thanks for catching that. Okay, where am I at here on this side? Here we go. Okay. So levels of injury, here's a picture. Cool. What diagnostics would you expect them to run on somebody who... Kiddo, can you go sit down, please? No, I'm not done. Can you go sit down, please? Thank you. Sorry. What kind of diagnostics would you guys expect for someone who is coming in with a suspected spinal cord injury? I hope someone would get an x-ray. Just a thought. X-ray, some kind of imaging, maybe a CT scan. Not scam. We're not scamming anybody today. There we go. Scan. Because you want to assess for damage to spine. Makes sense, right? What else? Like, is there any other lab you guys want or any physical assessments that you guys want to do? I think MRI is a good idea too. It wasn't specifically mentioned, but I mean, all imaging I feel like is going to be a good idea. MRI can take a bit to process though. I think that would be the only reason that they might be a little hesitant on it. And some hospitals don't even have an MRI. I found that out. Found out the hard way. Yes, CMS and your level of consciousness. You can do level of consciousness using a Glasgow coma scale. I should probably write that out. How do you spell that? Glasgow, there we go. Coma scale. I know how to spell, I promise. But yeah, CMS, you're mainly looking at sensory and motor, if they still have function. Where are we at? I know I saw something else. Deep tendon reflexes is good as well, and that comes into play when we're talking later on about some of the complications and what to expect in spinal cord injury. So deep tendon reflexes, yay. Let's see, is there anything else you missed? The only other thing would be a pupillary response. So you're looking for because your brain injuries are going to have fixed pupils. Pupils, there we go. You guys don't have to know the Glasgow coma scale at this point, but you might have to know it in 240, maybe, who knows. Ooh, and then the other lab that they wanted you guys to do, oh, not the lab, excuse me. There wasn't a lab. I read that wrong. Yeah, I totally read that wrong. I'm so sorry. But the other thing that they want you to consider is airway breathing and circulation assessments first. Because like mentioned above, the higher the injury, the more risk of respiratory failure, spasming, the whole bit. If their diaphragm is unable to move, they're going to have an issue with breathing, so not going to last too long. Let me highlight that. This will be important. I feel like that's important. Here we go. Okay. Some things to remember with systemic complications. We have a couple different things. We have cardiovascular, GI, respiratory, GU as well, musculoskeletal, obviously, skin stuff. Like every system can be affected. Oh, that's an interesting way to remember this. I don't know if this was actually written anywhere in you guys' stuff, but I don't know why he put that there. But cardiovascular, everything goes down. So your manifestations, if I'm saying cardiovascularly, everything goes down, what do you guys expect to see? Yeah, some hypotension, right? Maybe some bradycardia up in here. Y'all gonna make me lose my mind up in here. And I don't think you guys went over it too much, but in 240, it's going to be very important for you to consider your MAP and your cardiac output is going to be really big. So when we're talking and looking at the combination of like really low blood pressure, bradycardia, stroke volume going down, we're going to have decreased cardiac output. So not enough blood's going circulated around. Big bad. Last thing is venous pooling. This doesn't really return as well. So what are some things that you want to do for these people? What are some interventions y'all are thinking about to kind of go against those? Oh, y'all went straight to pressors. Okay, so I'm being super lazy. I'm copying and pasting this. Forgive me, I know. I'm bad about this. Because I saw Lovenox already, that one makes sense. So preventing your DVT, so heparin or Lovenox, SCDs, range of motion exercises, I like that as well. But after spinal shock has passed, I want to emphasize that one. If we have IV dopamine for hypotension, IV atropine for bradycardia, NS wouldn't surprise me, but I think the main issue isn't inherently a volume deficit. It can kind of buffer you in the time being, but then we run the risk of them becoming fluid volume overloaded. So it's going to be, I mean, it's still technically here. I think they're going to do a little bit more of this. I mean, this is definitely less invasive. Might be a combination. I like the idea of oxygen too if they're having respiratory issues down here. So I feel like that's going to come up. But yeah, fluids, dopamine, atropine. I pray to God you don't have to do that, but it is what it is. Okay, so respiratory. What are some manifestations you expect to see from respiratory if someone has a spinal cord injury, like super bad spinal cord injury? Ow, jump scare. Atelectasis, pulmonary edema, pul edema. 10 out of 10. Yeah, neurogenic pulmonary edema, pneumonia, all this crazy stuff. Big bad lung stuff. Let's see, manifestations, copy paste. I love doing that. Thank God. Atelectasis, pneumonia, neurogenic pulmonary edema. This is some patho mumbo jumbo that Diego likes to put. Something about some kind of sympathetic response causes catecholamines, and those catecholamines cause fluid shifts. Weird stuff. I know he would explain it better than me. Forgive me on that one. I just know that it happens, to be honest with you. And with these things in mind, it makes sense that if your patient has pulmonary edema or pneumonia, that this patient's gonna have a hard time breathing and gonna have some impaired gas exchange. And depending on where their spinal cord injury is at, they could end up having ineffective breathing patterns. I found the number. Theron, I found it. Especially if I'll put this in red. This will come up. Especially if your spinal cord injury is above C4 and C5, you can end up having really big bad breathing issues. So what are some interventions you guys want to take to? Yeah. I was like, I know it's in here somewhere, but it has been a little bit since I've had to look at this, and it's been a while since I've had a spinal cord injury patient. So I was like, ugh, very specific. Yeah, so IS, turn cough, deep breathe, possibly a ventilator. That would definitely be if they were going into respiratory failure. And for your ventilator, you have your ventilator bundle. I, again, don't remember how much you guys went over of it at this point, but oral care is part of it. Having sedation vacations, because when they are on a ventilator with a tube down their throat, it is not comfortable. They will try to fight it. They're not going to like it. Suction, PRN, because if we have a whole bunch of gunk up in there, like I don't know how gunky y'all get when you're sick, but when I get really sick, I get really gunky and it like sticks in my chest and I have a hard time like trying to breathe and I'll just keep coughing and coughing and coughing trying to get it out. So suction PRN. You guys will learn more about the ventilator that bundle later. That's more for pneumonia, but same thing applies here. Head a bed up. Let's promote some good oxygenation. Where are we at here? Percussion and postural drainage. I could see how that would be for like if they have a lot of secretions as well. Possible percussion and postural drainage, secretion. That's a big word. That's a big word for Elmo. And obviously we're gonna be listening to lung sounds pop off, especially if we have that pulmonary edema. Actually, I'll put this here too. Put it down here too for pulmonary edema. That's not how you spell pulm. There we go. Lord help me. Okay. Moving into GI and nutrition. This one's not too big of a thing, if I'm honest, so I'm just going to talk about it. One of the things you can have is paralytic ileus, because, I mean, makes sense. Depending on your level of injury, you could have some kind of paralysis of it. Stress ulcers, if they're NPO and they're experiencing a lot of stress, I would be stressing out too if I was in a hospital. So they can also have GI bleed from stress ulcers, and listen to bowel. If it's absent, it's due to, I would say there's a big chance it is. It doesn't inherently mean so. There might be obstruction, there might be another problem, but in this case, probably. In this case, probably. So yeah, definitely listen to your bowel sounds and assess for any distension going on. That'll tell you like, hey, something's not moving along. For your stress ulcers, you're going to want to give a PPI or H2 blocker. Looking for any signs of GI bleed, either upper or lower. So our dark tarry stool, it's going to be a sign of like an upper one that's moving all the way down and out. If they have poor nutrition and they're starting a third space or whatever, you could give albumin. And then TPN if they really need it, if they go past that threshold of time, being NPO. Remember though that that is very invasive. So if we can get away with doing things that are not as invasive, like if we could get away with the NG tube, if their bowels are still very active and not in paralysis, then then we'll look there as opposed to TPN. But if they're experiencing paralytic ileus, they're not moving stuff along, we're going to probably go more towards TPN. Let's see. This is important right here. I'd say this is important. I don't know why he didn't put that there. I think it's important. So your bowel manifestations are gonna differ depending if you have where the level of injury is at. So if it's above T12, which is thoracic 12, like the kind of bottom part of your rib cage, and up, you're gonna have a different type of manifestation. And then if it's below, so if it's above T12, what do you expect to see? Like super poopy or super not poopy? Pop off, queen. Yeah, so reflexive bowel. So they're going to be incontinent, and then below T12 is going to be the opposite issue. They're going to be constipated, super constipated. So this is the fun part of this one. Some interventions for that. Yay. So some interventions, depending how bad their constipation is, they may need a digital disimpaction. Good times. I don't, to be honest with you, I don't know if we as nurses have the capacity to do that. I think that's like a MD thing because you can end up causing like vagal nerve stimulation. Doesn't mean you're not going to do it, but I'm just saying. Dietary changes, lots of fluids, some good fiber in there. What is it called? Metamucil? I feel like that's right. Give them some Metamucil. Stool softeners, and then a bowel schedule. So rectal stimulation and glycerin suppository. I feel like that's more, all of this is more geared towards your constipation. The incontinence, really not much you can do about. Just kind of deal with it and clean it up the best you can. Make sure that you clean it well, that because if anything's left behind, it's really corrosive to the skin, like super corrosive, and it's just nasty. If I ever end up in a hospital and y'all leave me sitting in my poop, I'm coming after y'all. But yeah, and then like Mary said earlier as well, the above T12 for genitourinary, it's going to be a spastic reflexive bladder. So it's going to be incontinent. And then below T12, they're going to have some retention. So I'd say with your retention, all the girly pops know, the more you hold your pee, increased risk of UTI. So don't hold your pee, please. Don't do it. So we have two different meds for, these kinds of urinary issues. Which one would you use to treat incontinence? What's the name of that med? Anybody? Med to slow down the bladder and treat incontinence. Anybody? That's wonderful.
And not falling over. It might got
Oh wow.
it's a hook on it.
It's got a hook. Awesome. Okay. Thank you. Sorry guys. So ditropan and oxybutynin or oxybutynin, the generic name, excuse me. That'll be used for that. And then your botanical, your choline will be used for bladder movement. Let's see. Diego had a way to remember it. I feel like it's at the lower part of these notes, so I'm trying to find it right now. Where is it? No, I know it's here somewhere. I saw it. I saw it like yesterday. I think if I remember this one, he said instead of giving a bedpan, give ditropan. So instead of you giving them a bedpan because they keep peeing and peeing and peeing, you're gonna give them ditropan, fix the problem, so they don't have to deal with the other type of pan. I don't remember the one he said for the uricoline though. I'll have to ask him when he comes back out. So hopefully I get an answer on that one soon. Okay, so that's it for that. I would remember these two meds and which one does what. But that's just me. That's me, girly pops. All right, some musculoskeletal manifestations that you guys can conjure up. Conjure it. Yeah, you can have some spasticity, contracture if they're not moving it around very much. Bone loss, which could eventually lead into fractures and muscle atrophy because we ain't moving it. So, I mean, this one pretty much makes sense. Range of motion. Copy. I'm being super lazy. I'm just copying and pasting because I love it. Range of motion exercises to prevent the contractures. CMS, make sure that patient can actually feel and can, if they can perform active movement, that would be nice. And then keeping them in proper alignment would be really nice too, especially if they have a spinal cord injury. And our last thing is skin breakdown, right? So we know from first semester and we know from every Braden scale that you have done in your life to assess for risk of skin breakdown. These patients are at risk. They're immobile or they might be immobile. If they are peeing a lot, they have that spastic bladder and bowel, they might have very moist skin very often. And if they have that paralytic ileus or whatever the case might be, they might become malnourished. So, biggest interventions, you've heard it all your life. You're going to continue hearing it. Sorry, queens. Turn them every 2 hours and keep them clean and dry. Please don't leave me in. If I am a spinal cord injury patient of yours, do not leave me in the bed with poop on my butt. I will come after you in the afterlife. I promise you. Okay, let's see here. Interventions for spinal cord injury. So early/immediate immobilization. This is important so that you don't cause further injury. I've seen studies recently that kind of like, I don't want to say disproved it, but in terms for this class, you want to immobilize the spine as quickly as you can. One of the things you could use is a cervical. Hi. One of the things you can use is a cervical collar to keep their neck in place. When you're trying to roll them over, like if they have a bowel movement, and you need to wipe them, make sure you're log rolling them so that their spine and their neck, their whole spinal cord moves as one. Because if not, we could cause further injury. What is so important about doing something within the first 8 hours? What are we giving and why is it important? Solumedrol, why? But why? But why? Why? Prevent secondary injury. How does it prevent a secondary? Oh, Kayla already answered it. I just realized. My bad. My bad, Chief. Prevent secondary injury by reducing the amount of swelling. So again, we're dealing with another steroid, right? We talked about some of the side effects of steroids, and this is it's pretty high dose that you're giving. So some things to keep in mind, you could see some hyperglycemia, and they are at risk for reduced immunity and therefore getting sick. And then depending on how long you're giving it and how high of a dose you're giving it at, you could see some electrolyte imbalances like sodium increase and potassium decreases, edema, increased bleeding risk. I think these would be the two bigger things to look at. Other intervention, assess your ABCs, especially for above C4 and C5 injury. Oh wow, look, that came up again. How I didn't remember it the first time, Lord only knows. Why is that important? What happens with injury that's above C4 and C5? It could. I'd be afraid if that patient got ARDS. It could happen over the course of time. I like Lori's response. No breathe. I'm gonna copy that. Oh, I love that one. I'm sorry. It's sticking in my head now. Respiratory dysfunction. Yeah, because your ARDS is a very large, like, inflammatory response, and causes like lung scarring, a whole bunch of constriction and all this fluid accumulation too. So I was like, oh, I hope that patient don't get ARDS. Things don't surprise me anymore. It wouldn't surprise me if something happens to the point that they end up getting it. Assessing your CMS as well, and possibly a halo brace. Not like Beyonce though, unfortunately. We can't all be Beyonce and have our halos like that. So clean the skin under the vest to prevent skin breakdown. That's going to be a big part of that. Do you guys know what a halo brace is by any chance? Before I start talking on it more. Okay, yeah. It kind of looks like medieval torture. I realized Diego actually did not put a picture here, so I feel like this is a place where it's warranted. Personally. There it is. There she is. Cool. Yeah, so that's well, I can see her halo. Anyway. So yeah, so underneath these pins, really big risk of skin breakdown. So it's important to do your pin care. And also, this person's kind of stuck in this place, so it can alter swallowing. As for your pin care, make sure you clean it with gauze, remove the crusty bits. I think we just called them crusties. They have little yellow crusties around the pins. Think of Regina George. Forgot she ended up with that at one point. Oh, good times. I want to watch that movie again. I love that movie. So yeah, remove the crusties around the pins. Regina George would not like that. You don't want to use anything too irritating, so usually that's why it's just NS. And then assess for any signs of infection, which you guys all know the signs of infection at this point in time. I don't think you're going to be driving with this. I don't even know how you would like properly get into a car with it. I'd probably smack my head because I smacked my head on my car trying to get into it just normally. So I personally, I can't imagine. So don't drive. No bending, no heavy lifting. And since it is heavy, like this is, girl, this is all metal. It's thick, it's chunky. It's going to be heavy. It can alter your balance. You're carrying a lot of extra weight on you, so it causes fatigue. Walk with assistance. Now, CPR is a fun bit for that one. So they have this little wrench that's attached to the vest here. Oh, that is horrible. I can't imagine. That's a 100% no from me. No, thank you. But yeah, so for CPR, because you're kind of looking at this and it's like, huh, well, can't really do CPR with this whole thing in place. So they have a little wrench that's attached. I like how it just says know how to remove the anterior part of the vest to do compressions. I'm sure they're slightly different depending on which one you use. I've just never personally seen one, so I can't tell you how it is. But if you have a patient with one, please ask, because I don't know how to remove the front part to do compressions. But just know that there's something attached to it in the case of an emergency for you to do your compressions. All right, here's your big ones down here. So we have spinal shock, we're going to talk about neurogenic shock and autonomic dysreflexia, and that would be it for our spinal cord injury. Scroll back up, there we go. So spinal shock, that was one of the things I was talking about where it's like, well, might want to be pretty careful here. So spinal shock is basically right after the spinal cord injury, the initial injury happens, they have suppression of deep tendon reflexes, they might have a loss of sensation, and it might take a while to recover. So really, technically, we don't know how bad the injury is until spinal shock resolves. So that is something important to note here because like they might think that they're okay, we might think that they're okay, we might not think the injury is that bad, and then it's actually like really bad. But yeah, so flaccid paralysis below the site. Where are we? Here we are. Okay. So knowing this, knowing that it's like right after spinal cord injury, what are some things we want to do to kind of help move it along, prevent further injury, secondary injury, etc.? How are you going to go about your prevention of a secondary injury? Stabilize the spine and some roids. Some heckin' roids, yeah. So that's, oop, did I not copy paste this right? Nope. Nope, I did not copy it right. Oh, so sad. There it is. There we go. This is me being lazy again. Forgive me. So your IV corticosteroids, that's your Medrol, within 8 hours, basically ASAP, to prevent any secondary injury caused by inflammation. And then another prevention of secondary injury, immobilize the entire spine. Don't flex or extend the neck. Don't twist the body. Try to keep them laying flat. No sitting position until the doctor says it's clear. That is all technically correct too. It's all part of your immobilization. Imagination. And then, of course, we don't know how bad this injury is. We don't know how high the injury is either, right? So ABCs. That's weird that that keeps coming up. Wow, ABCs has come up a lot in this. How odd. Um, let's see. I like how he put this question. What is it considered done? And it's literally right here. We love that. So, how you know spinal shock has been complete is when your deep tendon reflexes have returned. There we go. That's what I wanted to do. So that one's not too bad. It's basically TLDR. We don't know how bad injury is. They're paralyzed. They don't feel too good. Give roids and keep them still and wait for reflexes to come back. And then we can actually figure out how bad it is. That one's not too bad. Next, moving into neurogenic shock. This one is the big bad. What are some manifestations? What are your big three that you're going to see? Not the priapism. Why was that? I'm sorry. I love that that was like the big three. The priapism. I mean, technically it could happen. But yeah, the big ones that are mentioned is hypotension, bradycardia, and warm and dry skin. I'm gonna put priapism here just for funsies. We love it because it could happen. So caused when there's an injury to T6 or above, leading to a loss of stimulation, blah, blah, blah. So T6 or above, risk of neurogenic shock. So what are you going to do if you suspect your patient's a neurogenic shock? You walk in, their heart rate's 40 something, their blood pressure's 90 over dead, and they're flush. Full send it. Send it. Atropine to treat the bradycardia. A pressor of sorts. Copy, paste. I'm being lazy now. Aha. Woo! Pacemaker would be a very permanent, well, it could be permanent or it could be temporary, depending on which one you do. I would pray that wouldn't be the case. Fluids as well. Pacemaker for the brain. What you mean? What you talking about, Willis? Brain pacemaker. I'm just looking through because I'm like, brain pacemaker. Well, I mean, I think, was it? Oh, ooh, deep brain stimulation would be big bad. No, it would be more cardiac. And it, oops, that's the wrong thing I copied and pasted. It would be more cardiac, so you'd have like maybe transcutaneous pacemaker. Worst comes to worst, transvenous. I hope it's not a permanent pacemaker insertion. But you guys will learn with your ACLS protocol with stuff like this, bradycardia, tachycardia, SVT, et cetera, et cetera, et cetera. When you have bradycardia that's unresponsive to atropine, you can do pacing. So that's another thing. That's where your pacemaker comes into play. Where are we at? I wanted to put that. Never mind. I didn't find it. Yeah. Pacemaker if ineffective. Definitely not going to jump to that first. I watched this video on deep brain stimulation the other day though, and like the initial trials of it, sketchy, like super sketchy. I was like, oh my gosh. Like they were just kind of shocking people just to see what would happen. For like lack of better words, they were pretty much just shocking people. It was kind of, it's not funny, but like I was just kind of taken aback by it. But yeah, so TLDR, neurogenic shock, low heart stuff, but they're super like warm, super sweaty. T6 or above is usually the issue. Treat your bradycardia, treat your blood pressure. Those are your main treatments. Moving into autonomic dysreflexia, this is a medical emergency. This is big bad. It's a whole bunch of extra mumbo jumbo. Travels up the spinal cord, evokes a massive reflex sympathetic surge from, oh God, thoracolumbar. That felt right. Sympathetic nerves and causes widespread blank. Jesus, why'd he have to say it like that? But yeah, so whole bunch of stimulation to the whole bunch of stimulation from the nerves leads to vaso something, which then causes something else to happen. What are the somethings? Vasoconstriction. What happens when we have vasoconstriction? Hypertension. Sorry, hold on, guys. Okay, sorry. Yeah, so hypertension, and then brain attempts to compensate for that. It's like, oh dang, like too much is going out. So let's like decrease our heart rate. Let's just calm it down to try to compensate. So that's the big bad. Goosebumps is a manifestation that you can have. There's a couple different ones you can have. Goosebumps is one. Where else are we at? Oops, not causes. Oh, let me go into causes first. So it's important. I would say it's important here, and congestion is another one. It's important here to know what causes this, because if we know what can cause it, we can prevent it and or we can treat it. Could be a kink from a catheter. Why is that important? Full bladder. Super important. Bowel impaction. Oh, there's your digital disimpaction. It's basically anything that's a stimulus or pain. Yeah, and that includes your clothes being too tight. Clothes too tight. It could be something as simple as somebody left the cap of the lancet underneath the person and it's causing stimulation to them. So it's a stimuli. We're having just this continuous stimuli, or it's painful to them. It could be anything along those lines. The ones that were given to you was like the full bladder and the constipation, but basically it's anything that can cause stimulation to the patient or any pain. So that's like an umbrella term for it, I guess. Okay. So we know, talking above about what happens with the vasoconstriction, we already know that this is going to lead to a manifestation of hypertension. And then when you have high blood pressure, we're worrying about some other stuff as well, because they're also probably going to have a headache, and we're thinking like, oh, the patient might have a stroke. Maybe might have a stroke. So headache, we know the bradycardia from what we talked about above. Goosebumps was mentioned, sinus congestion, just from all the blood flow, as well as this one was always weird to me, sweating above the injury. If I could spell that, that would be great. Sweating above the injury. And then the patient might just say, I feel horrible. I would too if my blood pressure was like sky high. and I was teetering on consciousness, I think I'd feel pretty bad too. That's just my thoughts though. All right, so what are your interventions for this? This one is important. I would know these. Call me because you need a friend. If you had a choice between calling rapid response team or head of bed up, which one are you gonna do first? Please do head of bed. Yeah, an ultimate fix is remove the stimuli. Whatever that stimuli is, remove it. So head of bed up first. This is important. Why? I was gonna copy and paste. Treat the cause, not the blood pressure. Big important too. Decrease ICP. Oh, that felt like so long ago that we went over that. Good times. But yeah, treat the cause, not just the blood pressure. Because imagine like I'm giving them a whole bunch of like blood pressure meds, and then we fix the stimuli, and now we've thrown them the opposite direction. That would be my kind of luck. I just want to throw that out in the world. Like that would be my luck. So rapid response team, because you're going to need help. But yeah, so treat the cause. That means if I could spell that, there we go. Identify the stimuli. Aha. Ahaha. Yeah, I think that's it. And then your vital sign parameters as well. I think just kind of have an idea of it for recognition's sake. So if your vital signs, if your blood pressure is greater, systolic is greater than 20 than what they've been at, like maybe something's going on. If all of a sudden they're bradycardic, maybe something's going on. I don't know. But yeah, that one's it for that. So TLDR, big bad, super hypertension. Body's like, let's not do that, and then drops itself out to try to fix it. Causes any stimuli or pain. So whichever one comes to your mind. Gotta pee, that's stimulation. Gotta poop, that's stimulation. Clothes too tight, like my pants are right now, that's stimulation. I would be in autonomic dysreflexia right now. I would not be having a good time. But yeah, I don't think they're gonna go too hard into these ones. These were the weird ones to me. Because hypertension and headache, in my head they kind of go together. Bradycardia, that's another, compensatory mechanism. Patient saying, I feel horrible. Kind of expect that. But sweating above the injury was always odd to me, the goosebumps and the congestion. But yeah, head a bed up first, treat your cause, call for help, call Ghostbusters, call somebody. I don't know. And then for recognition's sake, think about these. Hi. Thanks. Oh, come back. Wait, come back. What was the remember you had a saying for the uricoline?
Oh yeah. Fundaments.
Hold on, uricoline. There it is.
Yeah.
So I put this one here, but
Oh yeah.
I forgot what the other thing you said was.
It was uricoline if you need to urinate. Urinate. Uricoline urinate.
Uricoline to your innate. I thought that was a good way to remember that too. For me, my brain doesn't work too good, so I would probably just remember this one. I usually just try to remember one or the other, and then the other one will come to me, but that's just me personally. But here's his 2 ways to remember stuff. So ditropan, instead of giving a bedpan, give ditropan. And then uricoline to, did I spell that right? No. Uricoline to urinate. And that be it for spinal cord injury. Let me yeet this in the corner, download this. And then we will start on some questions in a short, hot minute as soon as I find where I put this at. Where'd it go? Spinal cord injury. There it is. All right, spinal cord injury. So I have questions for week 7 and week 8 content. If you guys had to pick one, just because I don't want to keep you guys like too long, and I don't know how long it's going to take me to go through the questions, Heike. Which ones would you guys want to do? Week 7 or week 8 content? There's no wrong answer. It's okay. I'm down to do both. Week 8. Yeah, because it's newer content to you guys, so it's like you know, there hasn't been as much time to settle in. And we just did the outline, so we'll see how it goes down. But this is a democracy. Is there like a thumbs up button for this? Oh, there is. But you know what? Put the nails if you like. Oh, never mind. Put the thumbs up if you like it, and put, I don't know, like an angry face. Not the democracy. We love to see it. Anyone objects, say aye. I don't know. Oh, where'd my window go? There it is. Okay, so I just pulled it up for you guys. Now I have to figure out how to share the screen again. It always takes me so long to figure it out. Forgive me. I think I shared the right side. I did, I think. Yeah, this is the right side. I always have to check. Because I have like the answers on the other side for myself to look at. I know it's cheating. I'm sorry. I'm sorry. Let me make this a little bigger for you guys. All right, guys. So how many questions do I have? I have 14 questions. Love that. Love that for her. So question number one, you have a client with a spinal cord injury, or a client with a spinal cord injury is prone to experiencing autonomic dysreflexia. The nurse should include which measures in the plan of care to minimize the risk of occurrence. Select all that apply. Okay, awesome possum, guys. Yeah, so A, B, and my mic is hitting my chin. A, B, and D. So make sure you keep the linens wrinkle-free under the patient, prevent any unnecessary, um, any pressure to the lower limbs, or I guess in general, really. And turn and reposition at least every 2 hours, because if we have any kind of stimulation to them or any pain, that is a big cause. So that's good. Good, 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 good. Number two, the nurse is evaluating the neuro signs of a client in spinal shock following spinal cord injury. Which observation indicates that spinal shock persists? Persist. All right, if anyone else wants to put an answer in, please go ahead. If not, we will discuss. All right, cool beans, guys. So yeah, flaccid paralysis will indicate to you that your spinal shock is persisting because everything else is some kind of reflex, hyperreflexia, super reflex, positive reflexes. Cool. Reflex emptying of the bladder. So bladders, not the batter. Oh my God, the bladder. So all of these are suggesting that there's some kind of reflexes that are returning. So that would indicate to me like, it's actually, you know, the spinal shock's ending, but flaccid paralysis indicates to me that they're still in spinal shock. So C is the answer for that one, guys. Number three, nurse is caring for a client who sustained a spinal cord injury during administration of morning care. Client tells you he just doesn't feel right. Nar. You take his vitals and blood pressure is 168/99 with a heart rate of 47. Which initial nursing action should the nurse take? All right, anybody else? I know I'm going through a little quick, but I figure the more questions I'm able to give you guys, the more comfortable you guys will feel. Cool beans. All right, yeah, please elevate the head of the bed first. We talked about this. It's to decrease any increased ICP because I don't want my head to blow up personally. Um, I don't know why you would put a finger up there personally. I don't even know why that would be your first response to this situation, but pop off. We already have the patient's blood pressure, so I'm kind of looking at it. I'm like, this is a little bit more urgent. Placing the client in a prone position is definitely not going to help anybody. All right, so number 4, nurse is caring for a client who is brought to the hospital emergency department with a spinal cord injury. The nurse minimizes the risk of compounding the injury by performing which action? This is a twickie, I promise. Y'all, I need to get a new phone. My phone is so messed up to the point like it doesn't charge half the time. My screen doesn't work half the time. The Bluetooth is so shoddy. Like I installed a new car radio and it works off Bluetooth and it'll just like keep disconnecting while I'm driving. I'm like, help. My GPS doesn't even work. If I need to go anywhere, I need to like throw it back to the early 2000s and like MapQuest myself there. I'll take a screenshot of the instructions of how to get there and just pray that I'm actually going the right way at this point. It's not good. Yeah, soon. That's what I'm telling myself, but for Father's Day, I'm gonna get my dad a new phone because he's experiencing like similar stuff as my phone. Probably not as bad. Um, but his phone's important for his work, so I'm like, yeah, I think it's time. I've had mine for a hot minute. I think I've had mine since like 2017. It's been through it. She's seen better days. Definitely so. All right. If anyone, I know I'm talking a lot, I'm sorry. If anyone else wants to answer on number 4, take a educated guess, an educated assumption, pray to the gods and pick A, B, C, D, eeny, meeny, miny, mo, whichever one you want to choose. Pop off. Yeah, this one was definitely a tricky. I'm sorry. I feel it. He's like feeling it out. He's like, it's this one. I can see it in my eye. Definitely would be a nice option though. If I could do it, I probably would. To be fair, I probably would. I don't want to move them myself. Barry, no, you have to. You're gonna have to move them at one point. Unfortunately, like if we could do that, that would be nice. But unfortunately, that's not. We gotta move them some way, shape, or form. So this one is actually gonna be log rolling them onto a firm mattress, not a soft one. Now, how many of y'all have gotten a new mattress recently, or like, went to the store and like saw this whole bunch of mattresses and you like lay down on one and you get the ones that are like super solid and you don't really move at all, and then there's ones you get and you like sink right into them. Because like high key, my back might just be old, but when I get the soft ones, it hurts my back more because my back kind of just like forms into like a curvature of the soft mattress. So I prefer my mattresses to be a bit more firm. Don't know why it works for my back like that, but I know it does. So for some reason, this makes sense in my head. But the idea of log rolling it onto a firm mattress is your spine won't really adjust to the curvature of of a firm mattress as it would to a soft mattress. So it's the best way for stability. Sitting them upright, big bad. And then simply keeping them on the stretcher doesn't really help us for proper immobilization, unfortunately. Plus, we got to get them to a hospital bed. I'm sorry. But yeah, so answer for that one was C. So onto the firm mattress. It was a Twickie, I promise. Number 5, you have a client with a probable minor head injury resulting from a MVA, admitted to the hospital for observation. The nurse leaves the cervical collar applied to the client in place until what happens? Why? When are you leaving it? When do you take it off? Who's all here today? I feel like I didn't take a good look at who was all here. Wait, I swear Jackie was here at one point. I swear she was. Huh. I might just be tripping out. I don't know. Okay. But yeah, if anyone wants to take a educated assumption, pop off, sis. Okay, cool beans. So answer for this one was D. We want to know what imaging has shown us because we want to make sure that we can rule out any cervical spine injury. If you remove that beforehand, like families here, and you're like, oh, like they just got here, but like here, let's take the collar off so you can move your head and cause a secondary injury. Pop off. Now, we need to do physical care. I don't care if it makes your life harder. I'm sorry, but I don't want that going on my take role like Mr. Roger. I know you came in. I know I'm bad about that. I see people come and go. So like it was at 15, now it's at 14. I watch it. How often do we do skin checks for these or for C collar? I mean, I would probably I would assume this is an assumption that it would follow the same policy as just like regular hospital checks. So that would be, I mean, depending on what unit you're on too, because to be honest, some people don't look. If you're in an ICU setting, it should be every shift. So during shift change, you should both be looking and doing a skin check. That would be my assumption. It would be the same thing for the C collar as well, but I can't definitively say. That's my educated assumption personally. You're not going to get tested on it. Don't worry. I promise you'll be fine on that front. All right. Number 6, a client with a C6 spinal injury would most likely have which of the following symptoms? Harnar. All right. Anyone else want to put an educated assumption and share our feelings today? Cool beans, guys. Yeah, so for number 6, it's going to be tetraplegia. That was just from that little like chart thing we did before with the levels of injury, which I'm just going to temporarily copy and paste right here because I'm lazy. So C3 to C5 was diaphragm. C4, C5, anything above that's breathing issues. And then here's our quadriplegia slash tetraplegia, C1 to C8. Oops, oops. There we go.
Caitlin, I have a question.
Oh my
What
God, you
does-
scared me.
I'm sorry. What does tetra? I know what quad is, but what is tetra? Like three?
So that's what I always thought, but here's the picture associated with it. Honestly, it kind of just looks like the whole body. Let me look up the actual definition if I'm being honest, because Miss Girl, I don't even fully know. Let's see. Oh, that's horrible. Yeah, it pretty much is everything. Tetra meaning four. I always forget tetra can mean four, like Tetris. Tetris, yay. So loss of function in all four limbs. So arm and leg and torso typically due to spinal cord injury. But yeah. So it's whole persons, basically. That is horrible. Oh, that's a sad thought.
So that must be the worst one then.
I would say that's pretty bad, personally. I wouldn't want to be there. But yeah, I agree with you. That one's probably the worst one out of all of them that you could have. But that's my opinion. But yeah, so for 6, that tetraplegia, so Miss Girl's gonna have a good rest of her life. Number 7, a 30-year-old was admitted to the progressive care unit with a C5 fracture from a motorcycle accident. Yikes. Which of the following assessments would take priority? Darren was just like waiting for me to ask this question. He was just like slammed the enter button. Slammed it. I mean, that's probably a good thing. I think that's a good like idea to have in your head. So the common things that they'll really test you on. I mean, neurospinal cord injury and like the endocrine stuff, like half of your exam is going to be just that. So you're going to get asked a lot of questions, but I wouldn't be surprised if a question or two came up about that. Just a thought. Just a thought. It wouldn't surprise me. All right. Anyone else for number 7? If not, it's okay. I understand. Yeah, so number 7, respiratory rate, please. So that's C, respiratory rate. So C4, C5. At that point, you're looking at respiratory issues. Yeah, so I think on the I just had it up too. Was it C3 to C5 controls the diaphragm? So that is one of the one that controls diaphragm. Anything that is above C4, C5 will be an issue with breathing. I think that's it for that one. Yeah, that's pretty much it. I have like in the rationales, I have a lot of stuff that's written and I'm like, it's a lot of it's very extra. So I'm like trying to cherry pick what's actually important out of that. All right, number 8, while in the ER, a client with C8 tetraplegia, RNAR, develops a blood pressure of, 80/40, pulse of 48, and a respiratory rate of 18. The nurse suspects which of the following conditions? She's struggling. Yeah. Awesome possum, guys. Yeah, so neurogenic shock is seen by our low blood pressure and our low heart rate because we ain't even trying to compensate anymore. And then your like 3rd most common quote unquote symptom is the warm and dry skin. But the priapism is still funny to me. I'm sorry. It is funny. But yeah, so neurogenic shock for that one. Number 9, a client is admitted with a spinal cord injury at T12, has limited movement of upper extremities. Which of the following meds would be used to control edema of the spinal cord? Yeah, or solumedrol, right? So solumedrol, let me actually change it because I in the rationale I actually put within 24 hours. I think they recommended within 8. So basically used ASAP. Use it to reduce inflammation, reduce swelling, limit any secondary injury that could be occurring. Please don't choose Lasix, please. Please don't choose Lasix. Number 10, which nursing task would be most appropriate for the nurse to delegate to the unlicensed assistive personnel? Our CNAs, our backbones. Yeah, cool beans. Yeah, so they can assist with the bowel training. So the answer for that one is C. So if it's already like the plan's already in place, they just have to follow through with it. They can't administer the tube feeding, obvious reasons. They can't teach something, and they can't really observe them demonstrating a self cath technique because then that requires a level of assessment to determine like, is this correct? Is this not correct? But yeah, so C on that one. Bring them to the toilet. We're almost done with this one and we're still making good time, so we'll be able to do week 7 as well. Number 11, a client diagnosed with ALS is dealing with muscle spasticity. Which of the following meds is most likely to be prescribed? Prescribed, prescribed. I have a weird way to remember this, and I don't know if anyone else remembers it like this, but I don't know. So yeah, here's your first question with chronic neuro at question 11. Yay. I just realized Khaled put V and then it was like, just kidding, B. But yeah, so for number 11, baclofen, I don't know why this helps me remember this, but I think baclofen and I think somebody's back, and I think like when people have muscle spasms, I don't know, for in my head it's in back because I get like back muscle spasms. So it makes sense that if I have a back muscle spasm, I'm gonna give baclofen. If that helps you, cool. If it doesn't, just ignore it. But yeah, so that's a muscle relaxant. First drug of choice for muscle spasm with ALS, MS, and MG. Please give that. Please. I was like, I've had so many weird random ways to remember stuff, but it got me this far, so it I was doing something right for me. But I know that like I've got some weird ones. Like I was explaining one to Diego the other day about how you place patients into the position for thoracentesis and like how I remember it. I'll say it at the end. But it's just like a random way me and my friends came up with, and it's like dumb. It's just dumb. Anyway, number 12, select all of the true statements about the patho of multiple sclerosis. All right. Anyone else? cool beans. So answer for 12 is B and C. So you have the damage of the myelin sheath from the immune system. Schwann cells, God help me, um, produce myelin in the peripheral nervous system. MS specifically affects myelin in the central nervous system. Blah, blah, blah. Lord help me. So B myelin sheath made up of Schwann cells is damaged along the axon is true, and this disease affects the insulating structure found on the neuron in the central nervous system, not peripheral, central. Central. I was just looking at the rationales and I was reading it off of there and I'm like, ugh, it's a big old paragraph. Let me just shift back over here. But yeah, B and C on that one. I know that's a random question. Forgive me. A patho question from me? Ugh. All right, 13. A patient with multiple sclerosis has issues with completely emptying the bladder. The physician orders the patient to take blank, which will help with bladder emptying. I'm sorry, I know how rude I was for only giving you guys one name. Forgive me. But it will happen in your exams. All right, anyone else for number 13? All right, cool beans, guys. So answer for this one is A, botanical. That's the uricoline. So you're gonna get, oh, I didn't know half of the drugs on the Kaplan farm, so it's okay. I'm so sorry. That's why I think I mentioned it. I was like, it felt like there was like a really split divide where people did, well, and they got the full points, or people didn't get any points, or like 1 point. It was a pretty big divide on my class. I didn't think it was that bad, but again, I might be biased just because did, I was a med tech before, so there was a lot of meds that I'd seen before, or that I had seen from me, like watching a whole bunch of videos in between me waiting to get the Cerritos about farm. I don't know why I did that. It was horrible. I would never do it again. Ugh. Um, but yeah, so botanical, that's your uricoline. So you give uricoline to urinate. So it helps with bladder emptying. The oxybutynin, that's your ditropan. So it's give them, instead of the bedpan, give them ditropan. So that will help them to stop peeing. There was one med that had like 10 ew. One med that had like 10 questions. That's ugly. That's ugly. Ugh. Forgive me. I know there it's like 80, is it 85, 75 questions? I don't know. It's like 70 to 80 questions, so that's like a good solid chunk. Ew. Right, this is the last one for our neuro stuff for questions. So number 14, a nurse is teaching a client who has ALS about a new prescription for Riluzole, which is also known as Rilotec. Which of the following instructions should the nurse give to the client? I will fact check myself. see where are we at. Dun, 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 e. Let's see here. Da, da, da. Oh, I don't have it in this outline. Yeah, the answer for this one was supposed to be C, but I'm double checking. I'm pretty sure it's supposed to be. I'm pretty sure it's supposed to be with food. Which technically, I guess, immediately prior to eating, sure. But I'm gonna double check myself real quick on that one, so I don't tell you guys the wrong thing. But it's not in the admin on empty stomach. Okay, so please don't give it immediately prior to eating then. That makes sense. Severe nausea. I have that written down on my side. Oops. That makes sense. Okay. So yeah, see, I was like, I saw a couple answers that said A, so I was like, let me fact check myself real quick. Make sure I don't tell you guys the wrong thing. But yeah, so with this medication being hepatotoxic, don't drink. I mean, that really goes for most meds. Don't drink, but this one especially. Anything that's hepatotoxic, that's probably going to be an answer. Yeah, this has like a whole bunch. Like I brought up the chronic neuro outline just so I could see how many side effects. So we have abnormal skin sensation around the mouth, diarrhea, dizziness, drowsiness, headache, loss of appetite, muscle weakness, nausea, vomiting, stomach pain, and Jesus. Monitor for neutropenia, admit on empty stomach, avoid caffeine, avoid alcohol, avoid smoking. Love that. Yeah. Oh, Jesus Christ, there's more. Yeah, so please don't drink. I mean, that goes for most meds though. Don't drink on most meds. Don't send your liver into overdrive, please. Okay, cool beans. So that's it for this one. Let me smack it into the chat and then we will move on to the next one. There we go. I was trying to make sure I chose the right file. Okay, let me see how I did this last time. If I just combined, oh cool, I did. I just combined the questions for connective and endocrine. I didn't make two different question sheets. I have 15 questions on that, so let me get this set up and ready for my shelf. And then I will share screen. Wrong screen. That looks right. I'm sure this is right. Right? Yeah. Okay. I always try to make sure I'm on the right screen and not on the wrong screen, because then I would just be showing you guys all the answers. That'd be my kind of luck. Okay. Cool beans. So this will be both connective and endocrine, just all week 7 content together. So number one, oh, let me make this a bit bigger for you guys, sorry. Number one, you have a home health care nurse visiting a patient after total hip replacement. What should the nurse include when teaching the patient how to protect the new joint? All right, anyone else for number one? Remember your hip precautions. All right, cool beans. So yeah, answer for this one is A, you want to put an extension on the toilet seat because we don't want them to flex the hip more than 90 degrees. Please don't tell them to cross their legs. That's a good way to just cancel out all the good you've done and just possibly dislocate it. But yeah, so put a little extension. Give them a little help. Make sure that they're not fully bending. Number two, which characteristic should a nurse recognize as indicative? Do you say indicative or indicative? I usually said indicative. Anyway, of rheumatoid arthritis. Get caught up on that for like a week now. You tell me, girl. Is COA? All right, is there anyone else for number two? A picture of a phone. All right, cool. Yeah, number two is going to be B. So rheumatoid arthritis we know is autoimmune and it's a whole bunch of systemic inflammation stuff. When we have systemic, we're going to have symmetrical stuff. So symmetrical bilateral joint swelling makes sense for RA. And yes, C is associated with OA. So like morning or evening stiffness, basically when they stop moving around, they'll get stiff. And then as they get up and moving, it's like oil in everything. Get warmed up. Stop being as stiff. And then it gets to a certain point where if they keep going and they keep exerting themselves past a certain point, then it's going to start hurting again. A fine balance you need for that one. All right. Number three, a nurse is caring for a patient immediately after total knee replacement surgery. What assessment requires a priority? Sorry if I'm moving kind of fast again. I want to make sure that you guys get through a lot, and I know that there's a good chunk of you that are responding very quickly, so just trying to get through it. Make sure you guys get exposed to as much. Right, anyone else for number three? Going once, going twice, going 5 times. I don't know. Number three, yes, quality of pulses in the affected limb. That's going to be super important because that sounds like the 3 Ps to me if I've ever seen one. You know, if you have pulses that went from +2 and all of a sudden it's +2 and plus nothing, you ain't feel nothing on the other side. Like, it's not good. Amount of pain, of course, that technically can be part of the 3 Ps or sorry, part of the 6 Ps as well. I was thinking diabetes for a second. I was like 3 Ps. No, it could technically be part of the 6 Ps as well, but it's pain that's unmanaged by like appropriate medication. So at this point, technically pain could be normal. Now, if I've given them a whole bunch of drugs and they're still in unbearable, excruciating pain, now I'm looking at a priority thing too. But at this point in time, quality of pulses. Circulation is impeded. Number four, patient is seen in the office for complaints of joint pain, swelling. Girl, I ain't even finished the question. Okay. Swelling and low-grade fever. What blood studies does the nurse know are consistent with positive diagnosis of RA? right, anyone else for number 4? All right, cool beans. So yeah, A, B, and D. So you expect to see a positive ANA, you expect to see inflammation like a CRP or ESR, and you expect to see that anemia, the red blood cell less than 4. Chronic anemia, low H and H. And yeah, I don't think I have much else to say on that one, to be honest. Like it is just that. All right, number 5, which of the following are usually first choice in treatment of RA? All right, anyone else for number 5? Cool beans. All right, so number 5, your first choice in treatment is usually DMARDs. All the rest of them could be used to treat RA, but usually you start with your DMARDs. So that would be like your what's it, methotrexate and your Humira for those. Oh, yeah, all the others can be used, but first choice is your DMARDs. All right. Oh, I just realized I never talked about this. I forgot to talk about it yesterday.
Wait,
The nurse. Oh,
I
sorry.
have a question. So for OA, would it be NSAIDs?
OA is not inherently an inflammatory condition, so it's not first line. But you can technically treat OA with NSAIDs. The first line for OA is Tylenol.
Okay, thank you.
Cool beans. Number 6, nurses gathering objective data for a client at the clinic complaining of arthritic pain in the hands. The nurse observes that the fingers are hyperextended at the proximal, interphalangeal joint with fixed flexion of the distal interphalangeal joint. Why did that come up 2 times? What does the nurse recognize this deformity as? Like a rosemary, Tylenol. Like all caps, Tylenol. Wait, I realized that this was something I meant to come back to, and then I didn't come back to yesterday. I forgot about hi. Is there anyone else for number 6? I know it was like an offhanded comment in your. No, I'm not hungry. Thank you. I know it was an offhanded comment in your guys's lecture, and then it was something I forgot to fully bring up yesterday too. Okay, so yeah, swan neck deformity. Let me put a quick picture of that in here because it's a gnarly looking, little gnarly looking copy image, paste image. There it is. See, look at the swan. So pretty. Yeah, those are oh god, that looks so painful. But yeah, that's the deformity that they're referring to. Fun stuff. Okay. number 7 now. So a female client asked the nurse if there are any conditions that can exacerbate systemic lupus SLE. Which is the best nurse response? Why do they gotta make so many big words? All right, known triggers. Any known conditions to exacerbate? My nose is itchy. All right, anyone else for number 7? Cool beans. All right, so for number 7, C is the correct answer. So pregnancy is often associated with an SLE exacerbation. I told a short little story yesterday. It was, again, another offhanded comment. You guys are probably like, oh, she has so many stories. I know. I'm sorry. About the patient I cared for, I think it was 232, that was having a lupus exacerbation, and she just had a kid like a month prior. So anything that causes a lot of stress is a big one. And hormonal changes. So for this one, the rationale I have for it is it's associated due to the rise of estrogen levels. Wouldn't surprise me if it's a rise in stress as well. In this economy, stress. But that's my opinion. So yeah, pregnancy often associated detergent. I don't think that's not gonna do nothing. Hypotension ain't gonna do nothing. GI upset, meh. SCA. Am I behind? What's the SCA? Oh, I was like, girl, what? Sickle cell? Yeah, yeah. Like same kind of stressors. Oh, my eyeball was itchy. Sorry. Okay. Number 8, a client with SLE being treated with immunosuppressant drugs and corticosteroids. Which precautions should the nurse provide this client? Select all that apply. All right, all right, all right. How many questions do I have on this one? I think I had 15. 15. I have 15 questions on this one, so we're almost at the end. We're at the tail end of this one. All right, anyone else for number 8? Cool beans. So this one is A, C, and E, so you avoid large crowds, please. Use contraception to prevent pregnancy and report any signs of infection to a physician. For most people, getting the flu shot is recommended unless they have like extreme immunosuppression. Where are we at? And then it's actually recommended for them to take aspirin or ibuprofen as well. So not inherently refrain from it. It's not, it ain't gonna do nothing bad. So yeah, no large crowds. You're usually taking stuff that can immunosuppressant drugs that can hurt an unborn child. So don't please use contraception and then report any infection to the physician since they're at increased risk of infection. All right, number 9, a nurse is caring for a client with SLE. I'm not reading that word, I'm sorry. SLE who is taking, oh God, Plaquenil. I'm not reading that word either. That's a big word. That's a big word for Elmo. The nurse understands that the primary concern with this drug is what? A lot of you responded already. All right, anyone else for number 9? Okay. So yeah, C is the answer for this one. Retinal toxicity. This is a anti-malaria drug, and one of the bad side effects is retinal toxicity and blindness. So I would if you're gonna know anything about that med, I would know that. Just a thought. Just my thought. My personal thoughts. Retinal toxicity. Love her for that. All right, number 10, a nurse is nurse is reviewing the plan of care for a client who has, oh God, SLE. I'm not saying that again. The client reports fatigue, joint tenderness, swelling, and difficulty urinating. Which of the following lab findings should the nurse anticipate? And this is select all that apply. Is there anyone else for number 10? Okay. So the answer for this one is going to be A, C, and E. So the positive ANA titer, +2 urine proteins, and elevated BUN. For this patient, we expect the opposite. For hemoglobin, we expect to be low because of pancytopenia, and then we expect the serum C3 and 4 to be decreased. The rest is all right because we expect to see, some kind of renal stuff going on. That was our big complication with SLE, is some renal stuff going on. So expecting to see an elevated BUN, maybe elevated creatinine and some proteins indicating renal damage. Wouldn't surprise me too much. And then that ANA titer due to it being an autoimmune disease. Cool beans. Decrease C3 and C4. I will double check myself though. I will double check myself. Where are we? I'm in the wrong section. That's why. Symphony. Where is it? I know I had it in here somewhere. You know, I was in the right one. Gosh darn it. Okay. There it is. I found it. Okay, so here was all the stuff. There. So there's all the ones from the outline from yesterday. So ANA positive, CRP and ESR, which are inflammatory markers, are high. A positive RH factor, low C3 and C4. What those are, I'm not sure. I'm sorry. I just know they're low. Renal stuff going on could be elevated. Looking at a UA for proteinuria and hematuria. White blood cells could possibly be high related to inflammation. LFT is elevated from some liver stuff going on there, all the vasculitis. Using an echo to look for pericarditis and pulmonary hypertension, and using chest x-ray to look for any pulmonary or cardiovascular issues. Not too crazy on that one. That one always, I don't have a rationale for that one, unfortunately. I don't even frankly know what a C3 and C4 is. I don't think I've ever seen that. Oh geez, it's a complement protein involved in the innate immune system. Low levels of both suggest activation of the classical pathway. I don't know what a classical pathway is, but apparently it's indicative of SLE. Yeah, they didn't go over it too much. Forgive me on that. Moving on to number 11, which patient is most at risk for developing SIADH? All right, anyone else for number 11? We're almost done, I promise. All right, so the answer to this one is A, so a patient diagnosed with small cell lung cancer. The reason for this being is that the tumors like to produce ADH and then leading to SIADH. Fun stuff. Oh, these are long questions, forgive me. What are some hallmark labs associated with SIADH? What do you expect to see? It is specifically for that cancer. Though other cancers could technically cause it, the small cell lung cancer is most notorious for it. So yeah, for SIADH, we're looking with dilutional hyponatremia because SIADH soaked inside SI. For osmolarity, never figured out the difference for one of the osmos. We're looking at hypoosmolarity. And au contraire for the urine gravity. You're looking at increased urine specific gravity greater than 1.030. Ironically, because we would think the opposite, right? Because the patient's fluid volume overloaded. So we would think like, oh, they're going to be peeing and it's going to be, a whole bunch of, just fluid. But They're not peeing very much, hence also why they're getting soaked inside. So whatever is actually coming out is very, very concentrated. So increase urine, you're good. Increase urine specific gravity. But yeah, those are your hallmark labs. So what's your management for SIADH? We love that. When do we give your hypertonic saline? Under 125, awesome. Your tolvaptan, your Vaptins, which are your aquaretics, those are good as well. Just something to keep in mind with those, that they get rid of the water, but they don't cause any real like electrolyte changes. But because of that, you can end up causing like a really quick increase in sodium. And that's no bueno. Risk of water toxicity. Let's see, where am I at here? So yeah, hypertonic saline, da da da. Da, da, da. That one is scary. It's a high alert drug. So just try to give it slowly and monitor the patient's neuro status very closely and their fluid status very closely. Let's see. Desmopressin risk for water toxicity. Where is desmopressin? Oh, that's the other one down there. Diuretics, sometimes you could give thiazides, they're preferred, but there was also mentioned like a low dose Lasix, which is fine as well. I just realized that's on the screen. There we go. Fluid restrictions as well, because they're already soaked inside their FVO, so try to restrict their fluids. Less than 800 ml a day if the sodium is greater than 125. And I think that's the bulk of it. I mean, then there's other stuff, of course, like keep the patient safe, do your assessments. Um, if the tumor from the small cell lung cancer is causing the issue, take out the tumor if you can. With our sodium levels, we have risk of seizure, neurological impairment. So watching your CNS and making sure that they're not about to have a seizure party in front of you would be a nice thing as well. Looking at their blood pressure and their heart rate. Think of like your heart failure patients, what they present like in that aspect with FVO. So high blood pressure, bounding pulses, maybe some tachycardia, tachypnea, maybe some pulmonary edema. We already talked about the urinary output. It's not a lot coming out because they're secreting so much anti-diuretic that they're just not diuresing themselves. And that's about it. All of the stuff I'm talking about is in it's at the bottom in the rationale. So I'm not just leaving you guys with nothing, I promise. It's in the bottom. I'm just reading it out. I promise. Number 14, diabetes insipidus diagnosis for the cause. So how are you going to figure out what the issue is with that? Water deprivation test. It's so cruel. I feel so bad. How long are we depriving the patient of water for? Like a hot second, 8 to 12 hours. I didn't even know they had that emoji. That's awesome. But yeah, so water deprivation test, what does that consist of though? I mean, other than the taking water away from the patient. Giving desmopressin, okay. Giving basically ADH, yeah. So why are we giving it? What's the purpose? Ma'am, why did you redeem? Sorry, that was like a dumb meme that Diego showed me, and it was like a scammer getting scammed. It's the ones where they tell you to like buy a gift card, and then like I don't know, like they take the card information from you or something. But the person ended up like redeeming the gift card, so the scammer was like, "Why did you redeem?" Sorry, I thought it was funny. Yeah, so to test if it's a lack of ADH causing it or if the kidneys are just being 1-800 that girl not reacting to it. She's not listening. She's her own boss kidney. So neurogenic versus nephrogenic. So with a neurogenic cause, what do you expect to see if we give ADH? Cool beans. Yeah, so increased urine osmolarity and a decreased urine output because we're giving them antidiuretic. So the brain issue was we're not producing it. We replaced it. Everything's good. The kidneys are listening today. Nephrogenic, you ain't gonna see no change. She said, I'm not changing for no man. I ain't changing for no ADHD. ADHD. I have ADHD. ADH. See, this is what I mean. I was like, I've been up since 4. Forgive me.
Caitlin, can you explain that one more time? Because if you give the water, when you don't give them the water, and if the kidney doesn't do anything, it's normal, right? It's the other one.
So with giving them the ADH, the desmopressin, if it's a neurogenic cause, because we're replacing it, you'll see an improvement in their symptoms. So you're going to see decreased urine output. If it's nephrogenic, that means that there's enough ADH in the body, but the kidneys are just not responding to it. They don't want to listen. So me just pushing more ADH is not doing anything. So with a nephrogenic cause, giving desmopressin will not change anything about how the patient is presenting. If it's a neurogenic cause, they'll have an improvement of symptoms, so they'll stop peeing as much.
Okay, all right, I got it. Thank you.
Cool beans. It's also in the rationale at the bottom when you guys get the document. So it's kind of that one's kind of like short. Some of them are kind of long. Like 15 is kind of long. I don't know why it's so long.
All right, thank you.
Yeah. But yeah, so that's it for number 14. Number 15, what's some general management, and then going into management specifically for nephro and neurogenic. It doesn't have to be in a big paragraph or anything. Just whatever point you want to hit on is okay. I realize it's like 3 questions in one. Yeah, giving desmopressin if it's a neurogenic cause because we don't the brain's not producing it, so let's go ahead and replace it, right? Low sodium diet. Yes, low salt diet for nephrogenic. Awesome possum. Yeah, and then what are some of your like general assessments that you'll do for either cause? Yeah, level of consciousness. We want to make sure that they're not about to have a seizure party on me. Preferably. Preferably not. Eyes and nose, very important. And whenever you see eyes and nose, you know she's married to the daily weights, of course. Seizure precautions, anything where it's dealing with the sodium content, I'd put seizure precautions on them. But it's more important for SIADH technically, but it wouldn't surprise me if you see it for DI as well. Although I don't think I actually have it listed there. But that's my thought process. I agree with the seizure precaution personally. Was one of the things that was mentioned to you guys was maintain safe environment. I'm like, that's so vague. That's so vague. IV fluids as well. You know, they're peeing out a lot of it. Let's just go ahead and try to replace it. Keep their blood pressure up. Keep them circulating okay-ishly. Keep their map good. Let's see, and that's pretty much it. And then just assessing their signs and symptoms of fluid volume deficit. So again, that blood pressure and heart rate, they might have tachypnea, they might be dizzy, they might be confused, etc. But yeah, that's pretty much it. Yeah, DI and SIADH aren't too bad. Making a compare and contrast chart for that and OA versus RA is really helpful, in my opinion. IMO or whatever. But yeah, that is it for that one. Save that, smack that over here. Where is it? Connective endocrine questions. There it is. But yeah, at this point, I know it's been 2 hours. If you guys have any like general questions, I know you guys have your test early tomorrow. I want to make sure that you guys actually eat, and have enough fluids, like Mr. Robbins says, enough fluids, and make sure that you guys, go to bed on time for your early test tomorrow. Because, at one point or another, it'll get to a point where there's only so much you can retain this late, of course. Like, it's like, what you know what you don't. Don't stress yourself out too much about it because, it's better for you to get good sleep and really emphasize the points that you really do know. Girl, she say I be sleeping at 3 a.m. on exam nights. Do not tell me that. You got me messed up. I be sleeping like a baby. Yeah, definitely it's fearful if you get like test anxiety. I know in the beginning of school I did. But I eventually just kept having to tell myself like it is what it is. I know what I know, I know what I don't, and if it's something I don't know, I have to take a breath and just try to rationalize through it. Oh, this is all extra. I'm just talking now. Oh, let me stop the recording.